Yes, welcome to the Tulip Airway channel. This is video number 5, and this video addresses the question of regurgitation, which seems to be pretty much the only question that we face, being that the Tulip Airway is in fact an oropharyngeal airway device. Okay, let's start with the basics once again. Alright, the oropharynx is where the Tulip Airway sits. The Tulip Airway isolates the oropharynx with a single high volume low pressure cuff, and it does so circumferentially within the single tube of the oropharynx, which is a unique methodology not seen in any other airway device. This, however, then gives access to both the trachea and the esophagus. The tulip here is sitting within the oropharynx. It sits from where the base of the tip of the soft palate, where the uvula is based, to the tip of the epiglottis, mass seal with a high volume low pressure cuff, entirety of the oropharynx. As previous video stated, it's a circumferential seal, so it's completely airtight, blood tight at this level. Now let's talk about esophagus and reflux, because that is, as I said, the only question we ever get. Now let's look at, first of all, the published studies already. This one is by Barker and Langton, and is regurgitation of gastric contents during general anaesthesia using a laryngeal mask airway. Now this is a comparative study between a laryngeal mask airway and a Guedel. Now, of 56 patients, notice no risk factors for regurgitation, so it's not expected. The patients all swallowed a gelatin capsule containing methylene blue 10 minutes before induction. Then the LMA group received fibre optic laryngoscopy and the Guedel conventional laryngoscopy. This was performed at the end of surgery. Now the results are slightly surprising. Basically the results are dye was observed in 7 out of 28, so 25% of laryngeal mask patients, but none with the Guedel. Now that basically concludes that the laryngeal mask is worse for regurgitation than a Guedel and a face mask, and the reason is quite simple. The tip of the laryngeal mask opens the esophageal entrance. Now some people insist that you can use laryngeal masks in potential regurgitation risk. I don't believe you can. One of the reasons is that when the laryngeal mask is being ventilated at higher ventilation pressures, it actually can leave the surface that it's supposed to be ventilating, the laryngeal inlet. It'll actually push away and leak, and when it basically pushes away and leaks, then liquid can get round into the laryngeal inlet, into the trachea. So even if you have a gastric drainage and all the rest of it, sure, that's not a bad thing, and the IGL having a gastric port is also not a bad thing, but it only takes a little bit of chicken and that thing's blocked. So in my humble opinion, the only way to deal with potential regurgitation and reflux risk is intubation. I don't accept that basically drainage ports and all the rest of it is an acceptable sidestep. I don't believe you should be using LMAs or IGLs in cases of regurgitation. I think it's intubation every single time. Otherwise it's unnecessary risk that you could well end up regretting. In the case of the tulip, because it's oropharyngeal, of course it doesn't offer any regurgitation protection in itself, but here's the good news. The tulip reduces the pressure you're currently using. And what I mean currently, let's have a look. So this is a consultant with a Guedel and a face mask, right? So that's current users, current experienced users who can get a result out of a Guedel mask and actually make a patient breathe, versus an inexperienced user versus using a tulip. Now, an inexperienced user is annually trained in basic life support, but is not anaesthetic. Now, with the consultant, notice this. These are averages of 60 patients, average of 19.4 centimeters of water with a Guedel face mask or consultant. You really do have to shove with a Guedel mask, and I think everybody who's good with a Guedel mask knows that. But the point is that is perilously close to the 20 centimeters of water that is supposed to cause stomach inflation. But look what happens. This is an inexperienced user with a tulip, right? They're generating 17.5 centimeters, so that's already 2 centimeters lower. So this is less pressure than a consultant is using today, yesterday, tomorrow. So an inexperienced user, an average of 60, it's producing 17.5 centimeters of water, right? So that's less pressure than a consultant. Well, you think that's great, but look, an inexperienced user with a Tulip is making 501 mils worth of tidal volume. The consultant is only producing 420. So a consultant is ventilating at 19.4 for 420 mils, and a Tulip ventilates at 17.5 for 500. So it'll increase the tidal volume by 20% and reduce by almost 11. Now, so that is, the best of both worlds. In fact, the word I've used is counterintuitive, isn't it? Anyway, more tidal volume for less ventilation pressure with a Tulip. And that's even when a new user, so those results of somebody who's never used a Tulip before, it's first time, is compared to a consultant anaesthetist. Now, I mean, that's probably as good as it's going to get. So the Tulip takes you away from the dangerous ventilation levels, provides you with significantly greater tidal volume, so you don't need the pressure in the first place. Okay, now this is important. Consultant anaesthetists generate excess, that's more than 20, ventilation pressure, more than 20 centimeters of water, in 39.7% of cases with a Guedel face mask, to achieve an average tidal volume of 420. All right, that's 60 anaesthetics. The inexperienced users with a Tulip generated more than 20 only 18% of the time. Right, they're not consultants. Now, the average tidal volume is 501. So the conclusion is that Tulip reduces potential regurgitation risks. I'd be interested in your comments. Now, additionally, you can use an orogastric tube, you can use endotracheal intubation through a Tulip. So if you're not happy, 1, you should be intubating anyway. 2, you can use an orogastric through a side port down the tube of the breathing tube of the Tulip, or you can intubate through the Tulip, if you so wish. Now, this is basically the position of the Tulip cuff, which then, of course, facilitates upper GI endoscopy, and hence orogastric tubes, again, both through the tube of a Tulip. So I recommend that you like and subscribe. That way you'll get notified of any of the further videos that we are going to release. There's another 3 in this particular series, looking into the, whether it's ethical or not, to use a Tulip or not use a Tulip, more to the point. Additionally, we'll be looking at the potential of the Tulip to replace Guedel mask worldwide for resuscitation and purposes of first airway line intervention. But I'd be very interested to hear what your comments are in relation to this regurgitation topic. I think it's a little bit better than most people expected in terms of the risk. It's been shown to be reduced to what people are currently doing. Now, it's also slightly unfair, I think, to ask a Tulip to provide the same levels of tracheal protection that an endotracheal tube does, because clearly if it was an endotracheal tube, there's no semi-conscious control. So you need to accept a small improvement in current conditions, because an increased tidal volume for less pressure, based upon the fact that the Tulip has the largest breathing tube of any airway device currently out there. So therefore the release resistance, because that must be an explanation, an increase in ventilation, a reduction of resistance, and a reduction of pressure as a result of the reduction of resistance. So I think it works the same as the way as electricity, I think. Well, so like and subscribe, and you'll be notified of the next videos, and I'll see you there.